Onassis Foundation. Dublab.
Welcome to the Quarantine Tapes, a daily podcast from Onassis LA and Dublab. Hosted by Paul Holdengraber, this series chronicles shifting paradigms in the era of social distancing.
Hello?
Hello, could I please speak with Dr. William Feldman?
This is him.
Hello, Dr. Feldman. This is Paul Holdengraber calling you from the Quarantine Tapes. I'm so happy and feel privileged to be speaking to you. Where do I find you, and what am I interrupting, or what are you about to do?
I just actually just ate dinner. I worked the night shift last night in the ICU and woke up just a little bit ago and just ate dinner.
What was the night like, if you could describe it for our listeners?
Sure. So it was a busy night. We have 15 patients currently in the ICU, and much of the night consists of making sure that they're on the right settings on their ventilators, and checking various labs, and just making sure we sort of keep everybody stable. And we also spent some time talking with family members. One of the hard parts about taking care of COVID patients right now is that family members can't come into the hospital. And so we have to communicate with folks over the phone, which has been a challenge.
Is this a new situation for you?
This is a new situation, yeah. Typically, patients in the ICU, they will be on the ventilator and may not be awake, and so we don't actually get to talk with the patient, but we really get to know the patients through their families. Their families will come in, they'll bring pictures, they'll talk to us about their loved ones, and so it's definitely it's challenging to sort of form those human connections with family members just over the phone, and of course it's extremely challenging for the family members who can't come in to see their loved ones. And so we're sort of in the middle of trying to relay what's going on and providing medical updates, but it's all very new.
It must be tremendously difficult. Dr. Feldman, if you don't mind my asking, could you introduce yourself and tell us a little bit about your specialization, your upbringing, and how it brings you to be now doing what you're doing in Boston, and where you're working?
Sure. So I am a pulmonary and critical care fellow at Brigham and Women's Hospital. I grew up in Charleston, South Carolina. I ended up studying philosophy as an undergraduate and did a doctorate in political theory before going to medical school. I'm interested in ethics and health policy, so I do research in both ethics and health policy. But I also work with patients in the hospital and spend a fair bit of my time in the ICU.
I read and found out that you are serving on the ethics committee at the hospital, and I am wondering what that might mean. I'd love to know. I had occasion to speak to one of your colleagues, Dr. Lamas, and I'm just wondering if you are providing her with guidelines too, and what that ethics committee might be doing, and how productive and fruitful the conversations, if indeed they are conversations, are at this moment when, in fact, probably the committee doesn't meet in person, or perhaps it does. I've asked so many questions. Forgive me.
No, I'm happy. I'm happy to answer them. I do sit on the ethics committee, and typically we meet every couple of weeks. different doctors, nurses in the hospital will call ethics consultations when a particularly difficult matter comes up. And on the ethics committee, we hear about those consultations and provide input. One of the things that we've been doing over the last several weeks is working on guidelines around resource scarcity. So as I'm sure you've read in the news that,
Yes.
One of the big concerns as the number of cases was ramping up in New York was that we were not going to have enough ventilators. And I think that that's still something that we have to think very seriously about, even though New York seems to be getting by with enough. But we started on a long process 4 or 5 weeks ago to really think hard about how our hospital would handle that situation if we had demand that was outstripping our ability to care for patients. So that's been taking up quite a bit of time for folks on the ethics committee over the last several weeks.
Preliminary guidelines were issued within a week, which is extraordinary. You must have worked very quickly. You were taken, in a sense, by surprise. What kinds of questions are you yourself asking yourself? And if you could, by force of imagination, bring me into the room where these conversations, these debates are happening.
Sure. So the kind of fundamental question that we're trying to ask is, how should we allocate resources when there are not enough? And that question has many components, but some of the sort of sub questions that we're asking have to do with how we should try to maximize good. So whether we should be trying to maximize the number of lives saved, or whether we should also be accounting for the fact that some people may be younger and have more life left to live. So that's one thing. We've thought a lot about healthcare workers and whether healthcare workers should get priority if we were in a position of scarcity. We've thought very hard about making sure that we don't kind of propagate any disparities that already exist. And so as we're trying to think about how we allocate resources fairly, we want to make sure that we do that without any bias based on race or ethnicity. So it's certainly been a challenging process. And I would say we've worked with folks not only at our hospital, but at another hospital in Boston. And this has really become a national conversation. Many states have come out with guidelines over the last several weeks.
What are the points of disagreement you have? I imagine, and we'll get to your philosophical training in a moment, but what are some of the, if you could, Robert Frost once said that a liberal is someone who doesn't take his own side in an argument. Now, if you had to, in some way, bring me into the room and say, some doctors may believe this and some doctors may believe that. What are the points of contention? What is the rub? I mean, you mentioned very quickly, people who have a longer life to live, people who have less life expectancy. These are incredibly complicated questions, and it brings to mind, though the comparison isn't great, it still comes to mind moments such as moments we know well in Sophie's Choice. And I'm just wondering, how these debates are going on behind closed doors, or perhaps now on a Zoom call.
Yes. So a couple of the big, I would say, points of disagreement. Number one, I alluded to just a little bit ago, but this question of whether healthcare workers, those of us on the front lines, should have some type of special priority for getting a ventilator or a dialysis machine or an ICU bed. In different states have come to different conclusions about that. And I think another big question is an area of debate is how much a patient's age or comorbidities might matter. And so, for example, New York guidelines suggest that what really matters in the short run is how sick the person is and the likelihood of survival in the very short run. Whereas some other states, like Pennsylvania, for example, have wanted to factor in patients' comorbidities, so that if even if somebody is likely to survive in the short term, that if they're expected to have not a long survival moving forward, let's say over the course of the following year, that should be accounted for in some way. So I think those are two important areas of disagreement. There are of course others.
Have you found that your philosophical training has helped you navigate this very strange moment we're living through? By strange, I mean where ethical questions of the hardest nature are being put forward to you.
It definitely helps. I would say it's given me a set of tools and vocabulary to have these conversations, but it's so different what we're dealing with in the hospital than what we deal with in the classroom. In this case, it's so important that we come to a conclusion, that we
Yes.
Resolve these disagreements, because without a set of guidelines for doctors and nurses and other healthcare workers, it puts people in an extremely difficult position, right? If I'm in the ICU and having to make personal decisions about life and death and triaging people without a framework, it puts a tremendous amount of pressure on the bedside clinicians. And so I think one of the goals of a lot of these philosophical conversations and guidelines at the state level is to remove some of this burden from clinicians. And so I think that my philosophy training has been helpful, but to be honest, I never imagined using it in precisely this kind of way, where it's not okay to say, yes, this is a hard question and kind of move on, but we really have to sort of get to an answer, and that's quite different.
Of course not. And I certainly didn't mean to imply that, but it is interesting to remember that philosophy, as described by Montaigne, and then Montaigne referring back to Plato, that philosophizing is learning how to die. And it's interesting for me that your background as a doctor, I think you're probably rare in that way, is a background in philosophy. And we'll get to that in a moment. I have a couple of questions about that. This word triage, which I know from the French-speaking world I inhabit in part, is so it's chilling in many ways. And I saw that you wrote a letter after Dr. Daniela Lamas published a very fine piece I found called "Who Gets a Ventilator?" And you had not really points of disagreement as much as you wanted to clarify where how your hospital handles questions of triage and who makes those decisions. So perhaps briefly you can let us know what the points of contention are, or maybe not contention, but the points of the way in which you needed to clarify what your hospital in particular does in terms of triage.
Yeah, it's a great question, and I think one of the hardest parts for doctors in this pandemic has been imagining what might come if forced to make these impossible decisions of triage. If you have one ventilator and two patients, it's not something that we're prepared for. It's not something that we're trained to do, and it's so different from how we practice medicine.
Yeah.
And I think that's it's scary to think about for all of us who work as physicians. And so one of the goals of our work on the ethics committee in the hospital has been to create not only guidelines as we've been talking about, but also a team that if we were in a position where we didn't have enough resources to care for patients, that it would be that team that that was making these types of triage decisions. And so rather than it being a person who's caring for a patient directly, it would be a separate team in the hospital that was thinking about triage for the whole hospital. And so I think Daniela's article was wonderful and highlighted some of the real emotional turmoil that we're all feeling, and that that we expect we would feel if we didn't have enough resources to care for people. But I think that what the sort of work we've done and that a lot of hospitals are doing are trying to alleviate some of those challenges. I think it's certainly the case that no matter what system is developed, no matter what guidelines are developed, no matter how great the triage teams are, if we ever got to that point where we're having to make those decisions, it's going to be challenging for everybody, for the people who are doing triage, for doctors and nurses at the bedside, for families. And it's certainly something that we all hope we can avoid.
Is there an appeals committee to the triage group? If
there is, and that's something that's been advocated by a lot of organizations nationally. There's guidelines from CHEST, which is a sort of national society for pulmonary and critical care doctors, and that's something that we think is very important. That patients and families have an opportunity to appeal any decisions that are made, and so many hospitals would have in place a type of oversight committee that would handle those types of appeals.
And the idea behind a triage committee or group of people is to create a sense of greater objectivity, right? So that in some way the doctor who's at the bedside of a patient might develop a certain relationship with that patient and might not see things as clearly as someone who might just look at the, for lack of a better term, I guess, life expectancy and the hard facts.
That's exactly right.
Chilling, isn't it? I feel for you and feel for the kinds of decisions, impossible decisions, really, where there certainly is no right answer. This is not a multiple choice questionnaire. There isn't a right answer.
That's right. I think there's not a right answer, and no matter what type of system one develops around this, there are limitations.
You studied philosophy, so take me back to that moment of being an undergraduate, and who at that time, and maybe who at this time, are your favorite philosophers?
Well, I grew up, as I said, I grew up in South Carolina. I went to a Hebrew day school, and I would say my household, the conversations around the dinner table were always very philosophical. As an undergraduate, I became interested in Greek philosophy, and I just remember reading The Republic for the first time, and was just mesmerized, and that sort of set me on a track of studying philosophy when I was an undergrad. And then in graduate school, I was really drawn to the ethics of war, and I read a lot of ethicists who wrote about war, like Michael Walzer, who I admire greatly.
I remember meeting. I studied in Princeton 100 years ago, and I remember meeting him and sitting in on a couple of classes. They were very impressive.
Yeah, I think his writing really grew out of Vietnam and thinking about all of the complexities there. And I would say now, the person who I look to in this current moment is a critical care doctor at the University of Pittsburgh named Doug White. And he's really done the most work, I would say, on coming up with some of these guidelines around triage and thinking about the philosophical principles underlying them. And it's interesting to hear myself say that because he wouldn't describe himself as a philosopher. He is somebody who is a physician and thinks very seriously about ethics, but is very focused on practical issues like the ones that we've been talking about today, or how we provide palliative care for people in the ICU towards the end of life. And I really admire his ability to both think conceptually in a very coherent way, but also the fact that he is a physician himself and is very attuned to the practical complexities that we're all confronting in the hospital.
What does he say? Because you say that he isn't a philosopher, and you're surprised to hear yourself say this about him. What is it about his point of view, as it were? And I certainly will look him up and hopefully maybe even bring him on the quarantine tapes to talk to us. But what is it about his approach that appeals to you? Maybe as a philosopher doctor or as a doctor philosopher?
So I think that that he what he's been able to do on some of these questions about triage is take an ecumenical approach, meaning that I think he's developed a type of algorithm and system for triage that can be appealing to a wide variety of people from a variety of schools of thought. And I think that his work has led the way in Pennsylvania, and I think other states have followed suit in following some of his guidelines. And so I think that, we've talked about some of these challenging issues, like how to prioritize whether healthcare workers should be prioritized and how we should think about disability and comorbidities. And I think he's managed to come to a position that it has fairly broad appeal. At the end of all of this, it's critical that whatever decisions we make about triage and about resource allocation are acceptable to people, and that there's some broad support for them.
In 2016, you published the book Privatizing War, A Moral Theory. What is it about?
So it's about military contractors and mercenaries that have been used by militaries throughout history. I got really interested in this topic because, as you may know, in the wars in Iraq and Afghanistan, the U.S. Military relied very heavily on military contractors. And so for every one regular military person in the battlefield, there was another military contractor, and they were driving truck routes and doing all sorts of different activities to support the war effort. And so the book really asks about the extent to which that's permissible. Should we as a country rely on private contractors to help fight wars?
What is the communality between your work as a political theorist and your work as a doctor?
I think that as a doctor, I'm encountering moral dilemmas all of the time. Especially in the ICU, we think about life and death. We think about, as you mentioned, kind of helping people get through very, very difficult times in their lives, and helping family members through them. And I think that my sort of philosophical work that I did before going into medicine has opened my eyes to some of the types of moral complexities that exist in the hospital. And so I find myself even when I'm in the ICU, sort of thankful that I've had these opportunities to think about ethics and philosophy, because I think it's helped inform the way that I practice medicine.
Little did you know that training would serve you now in the way it does. I wonder how you feel that the vocabulary of war is being applied to this pandemic.
So one of the things that we've heard a lot about in the hospital is this idea of moral injury, and that's a phrase that comes out of the literature on war. And the idea in the hospital is that when we put doctors and nurses in these terrible positions, making very hard choices, that it causes moral injury, that it pushes people to do things that they will think about for years to come, things that they feel that they did wrong because there was no way to do what they thought was right. And that's something that's been described in war, that when soldiers come home and that they don't just experience post-traumatic stress disorder, but that there's a sense in which they've been pushed to do things that they feel are wrong, and that they therefore suffer kind of emotional injury. And I think that it's an apt term to describe what we fear in the hospital, that particularly in this current pandemic.
In closing, Dr. Feldman, have the past weeks in any way changed your sense of what needs to be reformed in our healthcare system? And more than that, are there ways in which you think that this pandemic might change the way we provide healthcare to patients in the future, if one is to look at all in this moment of extraordinary trouble for a silver lining of some sort? Or since you studied in Hebrew school, I can use on you the term of Gershom Scholem when he talks about shards of hope.
Yeah, so, I hope that we do come out of this better as a healthcare system. I think that what I've seen working in the ICU over the last couple of weeks during this current pandemic is a tremendous sense of responsibility by healthcare providers to provide excellent care. I think that people have come together in the hospital in ways that I didn't foresee. And we're all sort of, those of us on the front lines are taking risks to help provide care for patients. And I think that sense of solidarity is something that will be beneficial as we move forward through this pandemic. I also think that this pandemic has highlighted disparities in the healthcare system, and it's highlighted how not everybody has access to healthcare in our country. And I hope that perhaps one silver lining in this is that as we move out of the pandemic, that we think harder as a country about how we can provide everybody with quality healthcare.
From your lips to God's ears, we hope. We hope. It's been a pleasure to speak with you, Dr. Feldman. Thank you so much for taking my call, and I certainly will look up Dr. Doug White. I'm very intrigued to find out what he's doing, and I hope he hears this conversation and knows that in your eyes he might nearly be a philosopher.
Well, thank you so much for chatting with me. I really enjoyed talking.
Thank you, and all the best, and thank you so much for taking the time now, and I'll let you get back to your meal. All the best.
Take care.
Bye-bye.
Bye.
To support this show and Dublab's progressive programming, go to dublab.com/support.